This Focus on Health segment is brought to you by Aurora Healthcare.
Hello and welcome to another edition of Focus on Health. I'm Jill Wunrow. Today we are at Aurora Medical Center here in Oshkosh to learn the facts about lung cancer from the hospital's thoracic surgeon and learn about new and better ways Aurora is finding to treat the disease. Joining me now is Dr. William Sacksteder from the Thoracic Clinic here at Aurora Medical Center in Oshkosh. Thank you so much for taking time out of your day to join us.
You're welcome.
We're actually here in the CT scan room, kind of a little bit of a medical atmosphere, giving us a hands-on look as far as what goes on here in this room. But first of all, tell me a little bit about yourself and what a thoracic surgeon actually does.
Well, I've been here in Oshkosh for the last 4.5 years. Came up here from the state of Illinois to practice here at Aurora Oshkosh in the capacity of a thoracic surgeon. A thoracic surgeon is a doctor who operates on the various organs in the chest. There are basically two types of thoracic surgeons: those who operate largely on the heart, cardiac thoracic surgeons, and what I do is non-cardiac thoracic surgery, operating on the other organs, which includes the lungs, the esophagus, the breathing muscles, the diaphragms, and potentially the chest wall itself.
Talk to me a little bit about, you mentioned the lung as being one of your areas of operation that you do.
Yeah.
Why is specifically lung cancer such a serious illness?
The primary reason is because it is so prevalent. Worldwide and nationally, it is the most common type of cancer that we deal with in the year 2009. Obviously, that has a great deal to do with cigarette smoking, in that that is the primary cause for this illness. At one time, breast cancer was more common in females, not anymore. Within the last 10 years, lung cancer has moved ahead of breast cancer as being the most common malignancy in females, and certainly it's the most common malignancy already in males. The other thing about lung cancer is that it's a deadly illness. The cure rate from cancers that are picked up early and operated on early and are considered potentially curable, to the lung cancers which are far advanced, even at the time of initial presentation across the board, the cure rate is only 20%.
And does the type of lung cancer, dictate as far as the influence on how it's treated?
Absolutely. There are two main types of lung malignancy: small cell lung carcinoma and non-small cell lung carcinoma. Small cell carcinoma encompasses only about 20% of all lung malignancies and is generally treated non-surgically, meaning it's treated with chemotherapy and also in some cases radiation. Non-small cell lung carcinoma, comprising 80% of all lung malignancies, the best treatment in most cases is surgical.
And what kind of tests do doctors typically run as far as, a diagnosis goes?
Well, many times early on, and this is one of the reasons that lung cancer is so deadly, it is not picked up early on. It's not picked up until late in its course when it is symptomatic. Frequently, lung lesions, lung cancers are picked up on chest x-ray, or they can be picked up also on screening CT scan, basically utilizing this technology that we're standing in front of right here. When there is concern that the patient does have a lung malignancy by either of those two tests, Frequently, the patient then undergoes biopsy, and that can be done in any number of ways. And after that is done, the patient frequently has what's called a PET, P-E-T, a PET scan, which gives us an idea of how active metabolically the lesion is and whether or not it's spread. And the final workup generally involves lung function tests, pulmonary function tests, which allow us to determine what the patient's residual lung function and capacity is if he or she is to undergo surgery.
And you talked a little bit about surgery. Are there specific patients that may or may not be suitable for surgical intervention?
Absolutely. When we see a patient, or when I see a patient as a thoracic surgeon, I assess the patient for the potential for operative intervention, and in order to be considered an operative candidate, obviously we're dealing now only with non-small cell lung malignancy, the patient has to fulfill basically 3 criteria. Number 1, he or she has to be medically healthy enough to allow the surgery to be done in the first place, meaning is the heart, the kidneys, the liver, other organ systems in the body, are they working appropriately so as to support the patient during and after the surgery? Number 2, as I said, we run the lung function test, pulmonary function tests, which tell me if the patient is to undergo a resection of part of his or her lung, how much lung is going to be left afterward, and depending on that, is this patient going to be able to breathe adequately, to oxygenate appropriately, and so forth after the surgery. And the third thing is we have to be certain that these people have not developed metastases. Metastases is spread of cancer beyond the chest. We as physicians know that lung cancer has a tremendous predisposition to spread, and potentially to spread early. That's why it's so deadly. It can spread to the brain, the liver, the bones, and we run tests before surgery to include PET scan and frequently an MRI or a CAT scan of the head to make sure that the cancer is still only in the chest and has not metastasized already.
And you just talked a little bit about the surgery itself, and last question for you. Are there new procedures to do surgeries such as the ones that you had explained, like using things such as maybe a light scope? How are those done?
Well, the primary way to operate, and this has been true back into the 1950s, going back 50 years, has been to go through a major incision, a very substantial incision in the chest, to spread between 2 of the ribs. Some physicians choose to resect a rib in order to gain access to the lung and hopefully to resect the malignancy. Within the last 7 or 8 years, we have progressed to the point we are now able to go in through limited incisions with the utilization of a lighted scope. It's called a thoracoscope. Visualize everything that we need to see and resect the lung cancer and the lobe in which the lung cancer resides in and the associated lymph nodes through this new technique. We do have this available here now. It has been available here at Aurora since January, and its benefits are the fact that these people generally post-operatively suffer with far less pain, they recover much faster, they're out of the hospital much sooner, and the most important thing is the fact that it seems, and all of this data has not been compiled yet, but it seems at this point that our ability to remove successfully the malignancy with the object being cure of lung cancer is equivalently good via the thoracoscopic approach as it has been for the last 50 years via the open technique.
Wow, thank you so much for sharing all that useful information to us, and a lot of new techniques here at Aurora. If you or anybody else that you know of is interested in learning more about thoracic surgery, please call 456-6000 or log on to lungcancer.org. I'm Jill Wunrow for another Focus on Health segment. Have a great day.
This Focus on Health segment has been brought to you by Aurora Healthcare.